afternoon, friends. Today we are in for a treat with two stalwarts giving us two great lectures. And yesterday was a National Safe Motherhood Day. So this is how to prevent maternal mortality. We have Dr. Sangeeta speaking later on. And at present, Ma'am Sharda Jain speaking on typhoid vaccination. She has been a very great teacher. Who doesn't know her? It's a privilege to introduce her formally. She has taught in 2 medical colleges, PGI Chandigarh and LHMC. She has been a great surgeon and has made a mark for herself not only in Delhi, all over India. Ethical committee member for Medical Council and then subsequently for NMC. And she has been given Lifetime Achievement Awards from IMA, Lady Harding, DGF, Hisar, Haryana Obs and Gynae Society. She got Corona Warrior Award from Delhi Medical Association, Delhi Police Achievement Award. There's so many. They go on and on. And she has been an advisor health to National Commission for Women and a chairman for
That's enough.
It's a privilege. It's a privilege for me to introduce our own Dr. Sharda Jain, who will be giving us pearls of wisdom.
My advice that please everybody mute yourself. Everybody mute yourself. Now we are passing through very, very bad times. Very bad times. There's a crisis all around and all records are broken. So I want ऊपर वाला हम लोग को कुछ याद रखे, हम लोग की केयर करे, उसके लिए एक छोटा सा मैं गाना गाऊंगी. शोभा जी सुनिएगा. जब कभी रोशनी दूर तक ना दिखे, जिंदगी में कभी जिंदगी कम लगे, जब कभी आदमी से डरे आदमी, जब दिलों में कभी प्यार की हो कमी, मालिक संभाल लेना, हमको संभाल लेना, सबको संभाल लेना, मालिक संभाल लेना, हिम्मत हमें तू देना, मालिक संभाल लेना. I can only, with these wishes, I can definitely say that I wish you people safe times ahead. You and your dear ones should be taken care of. I'm no expert of typhoid vaccine, but Abbott people believe that after I had taken 2-3 classes about flu vaccination, the flu vaccination rate in the city had increased. They want me to sensitize each one of you about the typhoid fever. And I will see to it that I do justice for the same. In the end, I will plead that this is one thing which you can all do for yourself and your dear ones. Let me just share and then I will do it. I come to my presentation. I'll just take a sec. मालिक संभाल लेना. So today I'm going to speak on typhoid fever, and again I say I'm no expert. But I think vaccination is the way forward. It is said that when it comes to prevention of infectious diseases, clean drinking water, after clean drinking water and toilets at home, promotion of food hygiene and hand hygiene, comes the vaccine, which have the largest contribution in saving life from infections. There are almost 27 vaccines all over the world tackling various infections, and the efficacy of this particular vaccine to the humanity is that right from 75% to 100% infections have been taken care of. There is a chart available where you can definitely know what is the efficacy. 99-100% efficacy is there. So in that particular light, today I'm going to talk about the typhoid fever, the problem statement, the lab diagnosis, the control of typhoid fever, the vaccines, and the small thing which is offered from my advice. We all know that typhoid fever, a common person also knows in this particular country. And when the common person knows about the country, that shows that it is a problem. It's a problem in the society. Please mute yourself. Please you mute yourself, so coffee वगैरह कुछ नहीं सुनाई देगी. It is the result of systemic infection caused by S. typhi and paratyphi. It is clinically characterized by typical gradual continuous fever for 3 to 4 weeks. There is a relative bradycardia with involvement of intestinal lymph nodes, lymphoid tissue, and reticuloendothelial system and gallbladder. I again repeat, it is intestinal lymphoid tissue, the reticuloendothelial system, and the gallbladder. It may be seen sporadically, epidemically, endemically. As far as we are concerned, India is an endemic place. It's only found in human beings. You can see here, our country stands tall. And we have, this Indian subcontinent has infected and categorized with a high burden area. By high burden, we mean that minimum 100 cases are there in 1 lakh population in 1 year. The medium which you can see is the light blue which is there. It is 10 to 100, while in the white area, wherever the globe is, it is less than 10 per lakh cases. So you can see the most common etiological source of bacteremia in Indian subcontinent is, and India stands tall here. Now, what is the USP of the typhoid fever in India? India is capital for many things. So it is 30% of the global burden occurs in our country. Another thing which is very important is that very frequently we find antimicrobial resistance in typhoid salmonella, MDR, multiple drug resistance. And it brings a significant morbidity and mortality reported in India due to typhoid fever. You can see in this particular chart the area which is marked out. This is a disease which kills our children, and that kind of things remains up to age 30 years. Thereafter, the decline is there. So it shows that if we want to prevent these typhoid-related deaths, we need something concrete to be there. And there is a need for typhoid vaccine. I'm glad that the pediatricians have taken it very supportingly, and cooperating in the country. Now comes the adult turn, and I will just dilate why we should be vaccinated as well. Look at the figures, because I'm going to just change this particular slide. The red which is marked is the number of deaths in a male and female occurring from 1 to 30 years. I don't have to tell about this particular disease, that it is transmitted fecal-oral or urine-oral route is there. We all must know about it. Then milk and the milk products, especially the ice creams, are the rich source of infection. So the incubation period is usually 10 to 14 days. It may be as short as 3 days. It can be as long as 21 days. Feces and urine which are infected, coming from the carrier, soil, our water, soil, flies, and fingers. From there, it finds its way to the food, especially if it is taken raw or even cooked. And then it finds way to the mouth of human beings. So the ingestion of contaminated food or water invade the small intestine and enter the bloodstream. From here, it is carried by the white blood cells into the liver, spleen, and the bone marrow, and they multiply and re-enter the bloodstream. Bacteria invade the gallbladder, the biliary system, and the lymphatic tissue of the bowel and multiply in high numbers there. And these are then passed on from the intestinal tract and can be identified for the diagnosis in cultures from the stool tested in the lab. Now, in the first week, there is a malaise, headache, cough, sore throat in the prodromal stage. Classically, it presents with a step-ladder fashion rise in temperature, taking as a peak over a 4 to 5 days, accompanied by headache, vague abdominal pain, constipation, and at times there is a pea soup diarrhea. In the second week, that is from the 7th to the 10th day of illness, mild hepatomegaly occurs in majority of the patients. Relative bradycardia is noted and may occur. The rose spots can be seen on the body. The patient will appear sick at this particular stage. Typhoid has a prolonged apathy, toxemia. The person may be delirium, disorientated, and coma. That's a serious problem. Diarrhea will then become apparent, and if left untreated, by this time, there is a high risk, that is 5 to 10% chances of intestinal hemorrhage and perforation, which is a very serious problem. All of us know about the complications because we have been brought up in this country, we have been trained in this particular country. So the complication can be general, right from the boil, tonsillitis to dehydration to severe mental confusion. On the medical problem, it can present as pneumonia, myocarditis, nephritis, neuritis, meningitis, any problems. Medical can be there. And the surgical side, I've just now told you, is intestinal hemorrhage and perforation. Now it is less. Previously it was pretty common. And it can present as osteomyelitis, it can present as paralytic ileus, it can present as pyelonephritis. So no organ is left where it is not invading. The lab diagnosis, we all know, the culture is the blood cultures are positive in the first week in 90%, in the second week in 75%, in the third week in 60%, in the fourth week, the incidence of blood positive culture comes down. The Vidal test, we all know about it. It is positive in the second and third week. Titer O is more than 160 and the type H is more than 320 is diagnostic. Preferably should be done on a paired sera, which is very difficult to do it. And after this, once it's positive, we treat them. The neodiagnostic test, just like a dipstick test and other tests are not, specificity is less. So those tests are still not marketed, though they are there. Typhoid fever can masquerade, and the differential diagnosis can be taken by anything, right from paratyphoid fever to paraenteric fever, gastroenteritis, brucellosis, tuberculosis, infective endocarditis, viral hepatitis, and malaria. It can present, anybody can think in different kind of things, and you can find finally it may be underlying typhoid infection. Now, as for the treatment of typhoid is concerned, the general management is very, very important. They require support in the term of hydration and the nutrition. I think one has to be very careful about this. The use of antipyretics has to be done very judiciously. I think sometime you give an antipyretic and they can be a fall in blood pressure. So one should use judiciously hydrotherapy more than the antipyretic agents. An appropriate nutrition, and at times, finding that the person is deteriorating because of the intestinal infection, there may be need of acute transfusions may be indicated whenever there is emergency is presenting. Now coming to antimicrobial therapy. Let's talk about hospitalization first. Whenever you find that the patient is looking sick and toxic, not accepting orally, inadequate urine output, altered sensorium and drowsiness, very high fever in the second week, look for complications. Better that the patient should get admitted. Coming to antimicrobial therapy, I will not be surprised at all that the people who have been practicing obstetric and gynecology, if they have to write a prescription for typhoid, they will fumble. So I thought I will recap that when the organism is typhi and paratyphi, what all medications have to be given. This is ceftriaxone, that is monosef, given in the dose of 50 milligram per kg. It is a drug of choice in pregnant patients, in children, in resistance to quinolones. Zifi, that is cefexime, 200 milligram to 400 milligram daily as a single, or it can be done in 2 divided doses for 40 days. General practitioners also use azithromycin. Again, this is 10 to 20 milligram per kg. Maximum dose for a day is 500 to 1000 milligram. Ciproflox, you can give her intravenously when the person is sick and hospitalized, 200 milligram IV twice a day. If you have to give it orally at home, it is 10 milligram per kg in 2 divided doses, and maximum it 750 twice a day. Management of complication, timely intervention is very important. Both physicians and the surgeons have to be on the guard that there is no complications. I told you the complications can be general, medical in every organ of this body, and the surgical complications. If there is intestinal, when the patient is hospitalized, the antibiotic of choice can be fluoroquine, but sometimes you find in some countries it is banned. So alternatives I have just now suggested. Intestinal hemorrhage, one has to take intensive care and monitoring, and if the need for blood transfusion, give it. Intervention is not needed unless there is a significant blood loss. Whenever there's intestinal perforation suspected, surgical repair should not be delayed longer than 6 hours. Triple therapy of metronidazole, gentamicin, and ceftriaxone to be given. Early intervention is crucial. Mortality still remains 10 to 30%. Typhoid fever with meningitis, characteristically the person has delirium and disorientation and stupor. The physicians prefer to give steroids in such patients for 3 to 4 days. Carriers need to be handled because they are the ones which has caused the problem of endemic condition in this India and Indian subcontinent. Food handlers are the ones which give rise to outbreaks time and again. Their screening and treatment is definitely needed. So any activities involving a fruit preparation and serving, those people must be taken care of. The chronic carrier state is 1 to 5%. Drug of choice is ciproflox, 750 milligram twice a day for 28 days. Alternatives are amoxicillin and cotrimoxazole. In some countries, the use of fluoroquinolones is relatively contraindicated in children because they may cause articular damage. We must know, and I had told it earlier, that there is problems of microbial therapy not effective. MDR. Many reports of reduced susceptibility and treatment failure for ciproflox is noted. Cefixime in MDR typhoid, significantly higher treatment failure rates than with Oflox or ciproflox. Chloramphenicol, all of us are scared to use this because of the risk of agranulocytosis, which may be as less as 1 in 10,000. Relatively high rate of relapse is noted, nearly more than 50% of cases, and the long treatment course of 14 days is required, and a frequent development of carrier state is there while using chloramphenicol. So in fact, people like me have probably not used chloramphenicol in my own practice for any one of my patients in the last 10-15 years. Now, the control of sanitation is very important. Besides clean drinking water, in our country, I don't know, somehow the pure water pipelines and the sewage runs together. And that's why it is very frequent, even in the city of Delhi, that sometime you find a water which is smelling like this thing, and they said that this is sewage line has contaminated the water supply. So one has to see the control of sanitation is very important. Protection and purification of drinking water is less is said about this, is less, because I think we should definitely get obsessed about the same. And promotion of food hygiene, hand hygiene, all that thing is very, very important. Now, how can a typhoid be avoided? Avoid risky food and drinks. The best drink is clean water. Ask for drinks without the ice cubes if you're taking it away from the house. Only eat foods that have been thoroughly cooked if you're eating it outside. Never take raw fruits and vegetables outside. Get vaccinated. Immunization need for vaccines against S. typhoid. It is important. And whenever the country thinks about it, whenever the WHO thinks about it, think about it that it is a serious public health problem, especially in Asia and in our country, because of the high prevalence area being declared by the WHO. The global burden is that, but we have 2 to 6 lakhs deaths per year, and 90% of enteric fever deaths are with us. Now coming to the vaccines in general. The first generation vaccine, for all of your information, are inactivated whole cell vaccine. The second generations are cell vaccine, which is live oral. Third generation are V1 polysaccharide vaccine. And then, because it is not that very effective, then comes V1 polysaccharide conjugate vaccine. And then talking about the paratyphoid conjugate vaccine. You can see here the new generation typhoid vaccine is around. Oral is not available in our country. The parental one is available. Earlier it was polysaccharide vaccine only, which is on the left-hand side. It was less effective. So it was polysaccharide conjugate vaccine has come. And that is what is being used. Now, concern about the polysaccharide typhoid vaccine had been, you can see here the polysaccharide and conjugate polysaccharide. What is the difference? It is T-cell dependent immune response is not there with polysaccharide because it has got a low immunogenicity, while conjugate, when it is combined with something else, is the efficiency and efficacy gets increased because it becomes T-cell dependent immune response. Immune memory is not there with polysaccharide, while it is there with the conjugate polysaccharide vaccine. Effectiveness is less than 2 years, which is not there in polysaccharide, and in conjugate vaccine, it is effective for 2 years. The efficacy, moderate and high. As for the conjugate polysaccharide vaccine is concerned, it's a high efficacy, and you find post-booster immune response is robust as far as the conjugate polysaccharide vaccine is concerned. So, what are the advantages of conjugation? The process wherein polysaccharide is a weak immunogenic is bound to carry a protein, thereby it increases the efficacy and immunogenicity of the final product, making it T-cell dependent. T-cell dependent immune response to polysaccharide is known, but that's weak. But when you combine it, efficacy is it makes it very effective. It is effective even in infants. So what is finally used is conjugate with tetanus toxoid. This is what is being used. Phase 3 trials have been done and there is a robust data. You can see the trials have been done, various age groups have been taken, and what it was found that the seroconversion 4-fold takes place once the vaccine is given at 42 days. Excellent immune response is seen in children and it is seen in adults as well. Long-term immunogenicity, that is seroconversion, and the 4-fold rise in the antibodies is seen more than 6 months and less than 2 years was tested. And it was found that on the left side bar, the efficacy was 98% at 42 days. But when it was tested at 720 days, the efficacy was almost 60%. This shows that a superior seroconversion is observed not only at 6 months, it was observed at 2 years, and that establishes the immunogenicity and efficacy of the typhoid conjugate vaccine. Long-term immunogenicity, more than 2 years and less than 45 years, where it can be given. The seroconversion rates were significantly higher in conjugate polysaccharide vaccine compared to only polysaccharide vaccine at 720 days. This again shows that the booster dose may not be required in endemic areas like this country. There's another test of efficacy is avidity index. Again, an indicator of protective immunity. Antibody response. Phase 3 clinical trial conclusion is that the efficacious because it induces 4-fold rise in antibodies, induces high antibody titer in children less than 2 years, proves superiority of conjugate vaccine over the only polysaccharide vaccine. Safety data is again robust. The single dose of typhoid conjugate vaccine is well tolerated, induces a robust and a long-lasting immune response. Recent data shows that the adverse events following immunizations are insignificant, 0.24%, and none of patients, it is serious enough to require hospitalization. No deaths have been observed. So the antibody avidity and its relevance is that this is a marker of its efficacy. The memory response are characterized by production of high avidity antibody, thus avidity could be considered a surrogate of successful priming. This slide shows that when the vaccine is given with booster, the antibody response remains high, but if the no booster is given, the antibody response over a period of time may come down. It remains 54% of the subjects. You may find the antibody response even at a later date. So the recommendation of Indian Academy of Pediatrics, the recommendation of CDC, and the recommendation of WHO say that children more than 6 months are required to have one dose, and this can be administered with MMR also. Our practice of our pediatricians had been till now that they were giving 2 doses, but now the WHO recommendations are very clear that the single dose is enough and you don't need to give a booster to them. The same had been the areas which are not endemic, the same thing was recommendation of CDC and WHO. As far as Association of Physicians of India recommendations for the adults are that this particular vaccine is preferred at all stages because of its improved immunological properties and expected longer duration of protection. Professional food handlers should be given. And when our country is in an endemic area, I think all of us should definitely have it. Typhoid patients after full recovery from illness can be given vaccine. It is recommended for travelers during outbreaks, and the dose is 0.5 ml intramuscularly single dose. Booster dose may be given after 3 years in areas which are where it is occurs sporadically or epidemics are there. Need for adult immunization is definitely there because I had shown you earlier that it gives rise to significant proportion of cases and deaths due to typhoids are seen in adults. Typhoid-related hospitalization cost alone is something like 50 to 60,000 in our country. The cost by outpatient department touches around 10,000 rupees. One attack of typhoid does not provide solid or long-lasting immunity from a future episode of the same illness. General recommendations to give typhoid vaccine at least 4 weeks after full recovery from typhoid illness is recommended. Who qualifies? It is a world-first clinically proven typhoid conjugate vaccine against typhoid fever to receive pre-qualification from the World Health Organization. How to vaccinate? The schedule of immunizing dose for adults and children and infants more than 6 months of age is a single dose of 0.5 ml. Booster dose may be given after 3 years, but it is not required as far as our country is concerned. As far as immunizing children are concerned, that for adults it is 1 dose. It is said that 1 dose is enough, and it is in endemic area because of repeated exposure. The second dose is not required. It means for we adults, 1 dose is enough. As far as children are concerned, again it is a single dose of 0.5 ml and the booster may not be required. Earlier, I just now told you the pediatrician had been using 2 doses, but now they have been recommended to use only 1 dose. When to vaccinate? Month-wise exposure has been seen, but as far as our country is concerned, the incidence of typhoid and paratyphoid is with monsoon months is the most vulnerable months. So before the monsoon comes, this particular vaccination, if one has to take, it should be taken prior to that. When to vaccinate? Variation of typhoid incidence. In our country, because the typhoid is observed throughout the country, vaccination can be taken anytime. Typhoid conjugate vaccine salient features I summarize again. It is a proven safe and a more effective than polysaccharide vaccine, induces high antibody response, even in children less than 2 years, produces T-cell dependent immune response, which creates vaccine immune memory, T-cell dependent and induces antibodies and neutralizes V1 antigen, unlike T-cell independent polysaccharide vaccine only. May provide long-term protection by repeat dosing if needed in areas where it is occurs sporadically or it is epidemic. Conjugate will not induce hypo response to subsequent booster dose. So take-home messages are that this particular polysaccharide conjugate vaccine is safe and immunogenic, prevents more than half of the typhoid fever cases, and these calculations of vaccine efficacy within the confines of a stringent challenge model are likely to be conservative estimates. So my recommendations are that this particular thing should be used, and whatever the information has been given to me, single dose is enough for adults. And as far as children are concerned, earlier practice of pediatricians had been 2, and they have been recommended to use only 1. So with these remarks, thank you very much.
Thank you, ma'am. So anyone wants any questions? Oh, welcome, Dr. You are there. I can see you.
Yeah, hi, good afternoon.
What is the cost of a single dose vaccine? What is the
Hello?
cost? Ma'am, what is the cost of this vaccine? Conjugate
The
vaccine?
cost of the adult vaccine, I don't know about the pediatric vaccine. Adult vaccine will cost you something like 1,800 rupees.
Ma'am, it is the same for all, ma'am. It is 1,800 rupees for everyone, ma'am. One single 0.5 ml.
Any comments by the experts? Dr. Deepshikha, Dr. Meena? I think, ma'am, it was a very self-sufficient talk. All the questions were already answered by you. Should we proceed with the